Okay, sure. Welcome to the June edition of the PCP Advisory Board meeting. It's been a quick follow through May to June, and now we'll have a little pause until September. But the good news about September is that we will be an in-person meeting at that point. So we're going to transition from Zoom only to in-person with Zoom combination. Being able to bring in folks from our more remote areas so they don't have to drive into Rochester for that. But it'll be fun to be able to meet everybody again and see each other, have good collaboration ongoing through that. And again, any suggestions people have for particular topics, feel free to reach out to me at any point to have go through. I'm going to pass the floor to Renee to make an announcement about the University of Rochester plan.
Thank you. I wanted to let folks know that you may have seen this on. Actually, Diego, can you move on? I'm having a committee member who's reaching out to me who's
Sure.
at the meeting in person for some
Sure.
reason. So I
Absolutely.
need to, so thank you.
So yeah, we'll take a pause on that, come back to that good news afterwards, and we're going to cede the floor to Dr. Bob Adams to kind of bring us together on the pharmacy results of 2022, and then to follow it up our conversation from our penicillin D labeling procedure that we had a conversation last month. Bob?
All right, how's everybody doing this evening? I'm going to share my screen. Can you all see it?
Yes.
Great. Okay, yeah, so I thought I would take a little bit of time to kind of review how 2022 went from a pharmacy services perspective. And just sort of to remind, kind of frame the philosophy that the pharmacy team goes at when we go through our, our day-to-day work with our embedded pharmacy team, and we consider the different initiatives that we work with Excelis as far as value-based contracting. We always keep what we call comprehensive medication management in mind. And, just to kind of bring it back to that, what it means, it's a systemic approach to medications where physicians and pharmacists ensure that medications, prescriptions, non-prescriptions, alternative, traditions, vitamins, the kitchen sink, everything that a person is taking is considered. And, how is that medication? Is it appropriate for the patient? Is it effective? Is it safe given their comorbidities? Are they taking it as intended? Is it affordable? And so, no matter how that patient gets in front of us, whether we're meeting with them because their A1C is high, we want to take a look at that person as a whole person and look at their medications and see if they're the right fit. And if they're not, make some recommendations, make some changes. That's kind of the framework that we have in our mind as we go forward when we take on initiatives or we meet with the patients in person. And, what does that kind of look like? So that CMM, that framework is where we start from. But of course, there's times where we meet with patients just to kind of do a med cleanup list, comprehensive medication review to see what's going on with that patient's meds, see if there's opportunity for us to engage with them. And a lot of times this happens too when we work with our community partners. We may be doing a handoff for some medication adherence work that the Rochester, the RMC team is doing on their community side, whether it's at Highland South Wedge or the outpatient pharmacy at Strong. So we do these medication reviews. And then of course, there's always those consults, just curbside, we need some help with dosing or regimen, or this new med came out, can you tell me more about it? Those are kind of the services that we tend to offer throughout the day when we're working with our providers. So how did we do? So looking back, we have a team of 9 embedded pharmacists right out in 12 different practices. So we did about 5,000 referrals last year. I'm going to go back to that one. For some reason, the whole slide wasn't there. There it goes. Okay. Don't know why I was not showing up all the way. But so of those 5,000 referrals, about 80% of them came directly from primary care physicians. So we know we're hitting, that's what we'd like them to do. we know when pharmacists go into a new clinic, they spend a lot of time, finding patients, running reports, doing things like that. But now we're seeing a shift where we're actually getting the referrals from the providers. And we feel that that's more impactful because it's the patients that you've identified that we could work with that would be most helpful. And, what are we talking about? 92% of those patients are either, uncontrolled chronic diseases, or they're medically complex polypharmacy issues. And again, that's kind of where we want to be. Those are the kinds of patients we want to be working with. So it's nice to see in the data what we're hoping for in our, in our mindset and our philosophy. And of those, patients that we've worked with in those referrals, we're following under that comprehensive medication management, a little over 1,700 patients. We've identified close to 6,000 medication problems with those meds, and it could be, high dose, low dose, side effects, patients not taking it because they can't afford it. And, in that process, we've entered in over 15,000 progress notes, kind of detailing the issues that we're seeing around these patients. And a lot of those progress notes are either for education for the patients or communication with providers. And how does reflect itself in the data? Well, the patients that we've been working with, we've seen an 8% drop in emergency visits for those patients over the last 90 days, 43% drop in urgent care visits, and a 17% decrease in inpatient OBS patients visits. Overall, about a 19% reduction in overall consumption of healthcare that's on that higher cost spectrum. Along the way, we've also produced 14 different pharmacy pearls this year in 2022, covering a lot of different things. Some of them were very timely in the fall and December. We had a lot of shortage issues happening with the medications, and we sent out several pearls on that. And we're kind of continually looking at different disease states. And these pearls are, a lot of times they come from you. So we're always open to ideas of issues that you guys may be facing in the practice for material that we could generate that would be helpful for you. Please don't hesitate to, reach out and say, hey, can you create something in this space? And we'd love to work on that kind of stuff more than just coming up with ideas that we think are helpful. We love hearing from the providers and understanding what are you facing that we could be helpful and what kind of material could we generate that would be of value for you guys. And then, looking at the dollars and cents of the issues, the different value saving contract initiatives that come out of Excellus or MVP. We have several different medication initiatives. In 2022, we saw a cost savings or cost avoidance about $10 million that we were able to generate. And a lot of this work is, through education, through changing the EHR record and working with the patients directly and using some different, chase lists and things like that, work that the pharmacists are able to do. We're able to show about $10 million in savings. And that's it. So, what questions can I answer about 2022? I'm happy to go back to any of the slides if you'd like me to.
Bob, I think that was very impactful, and it really shows how important pharmacy is, embedded in primary care. I can tell you that in our practice, having an embedded pharmacist is invaluable, and those CMMM, interactions are always helpful. And it's so nice to be able to go in and just say, hey, can I have a quick question here on this particular patient? And, Katie Deal, who's on our call here, will walk into the room, speak to the patient, have an interaction, give me suggestions based on that of what we can do. And as a colleague, be able to, discuss back and forth, both from patient perspective and pharmacy perspective, what we need to do in that space. And I think that is, tremendous. And this really represents the bigger picture of how that happens.
And Diego, if I can just add quickly your comments, appreciate your comments. One of the things Bob Adams and I talk about a lot and are planning for is going forward, how can we expand the services like you described from Katie, embedded in the practices. So more to come on that as we move forward.
I have a question about the decrease that you saw in emergency room visits and utilization of those services. Just wondering how you were able to quantify that, because were these people who were going to the ED multiple times that you could see a decrease, or were these just people that went to the ED once or twice and you monitored them for 3 months and it may not have had as much of an impact. Could you elaborate, please?
Sure, I'd be happy to. So that that kind of reporting comes out of the Epic EHR system. So whenever the pharmacists are interacting with a patient, that patient gets associated with that pharmacist. So then we can run reports on just kind of tracking that patient and how often that patient shows up into the ED. Now, it could be that there's no connection whatsoever between the pharmacist and the patient, but we tend to believe that it's not the case. We hope that, you know, the work that we're doing with helping with their medications, helping with compliance, that is what's leading, you know, looking at that patient over time prior to working with a pharmacist, they're sort of how many times they're visiting the ED or urgent care or getting admitted versus after working with a pharmacist and seeing those decreases. So it's the association electronically within a medical record between the pharmacist and the patient that kind of ties them together. And then we just track that patient, you know, afterward.
Thank you.
Any other questions about performance in 2022? I'd like to stress the importance of something Bob said, which is the pearls. If there are topics that we identify in our practices or that we feel that we would benefit from, I think it's very important to reach out to us. And I'm sure, you know, any pharmacist and Bob and myself, happy to bring that to light. So make sure that if you find a particular topic that you think we should review, let us know. You know, vaccines, for example, might be something that we want to learn more about, how to, you know, utilize those. So feel free to reach out. Thank you, Bob.
Yep, and absolutely. And, you know, a lot of the amphetamine shortages and amoxicillin shortages that were happening in the fall, like that was really coming from questions that we were getting hit with on many fronts from different providers. And so, you know, anytime that we start feeling that, hearing that from multiple sources, it helps drive us. But we're also, if you guys have issues that you aren't making it to us in any fashion, please reach out. We'd be happy to help assist any way we can. All right, I will switch presentation. All right, are you seeing one now titled Penicillin Cephalosporin Cross-Reactivity Alert Suppression and Community Collaboration? You guys see my screen okay?
Yes, we got it.
Yes.
Great. So I thought on the heels of the last meeting, kind of give you guys an update of what's going on, kind of a project that's in the whole Rochester area, collaborative between URMC, Rochester Regional, and, you know, and Monroe County Medical Society as well. So give you a little bit of a history. So back in 2022, in November, December timeframe, Jessica Stern and Jeff Huntress came to Therapeutics at Strong and, you know, presented the idea of, you know, reducing and eliminating the alerts that fire for patients who have a penicillin allergy that are being a prescription or an order is written for cephalosporin. So how do we suppress that? Because the evidence shows that that is not, you know, the cross reactivity is theoretical and not really real. And in fact, by withholding the more appropriate antibiotics, a lot of times there's downstream negative effects. So that, you know, that idea was presented to Therapeutics. There was a healthy discussion and it was brought back again in January, where the committee approved, yes, we feel that this is the right step. You know, large study of Kaiser kind of demonstrated this, thousands of patients. And so, you know, the idea was, okay, so let's move forward. Let's remove the discouraging that is in the EHR, within policies across Strong, as far as, you know, if someone has a penicillin allergy, don't give them a cephalosporin, give them another agent. So that work began. And as the group was talking, we felt like, you know, this would be really great as a larger community effort. So we started in February meeting with representatives from Rochester Regional to find out, you know, how do they feel about this situation? We know it's not, this is a common idea that's especially amongst like allergists and things like that, that in infectious disease, that this is not an alert that really means anything, and it often causes more harm. So in February, we met with the Rochester Regional team, brought the idea to them. had again another good conversation with several of their infectious disease specialists, with their pharmacy team, and agreed that yes, this is something that as a community we can all embrace and support, and know how do we go forward and kind of start to change this dogma. So we met with them, and then we met again in March, continued the conversation. Jeff's team created grand rounds on this topic that was presented at CE for the community. It's warehoused right now on St. John Fisher's pharmacy CE page. You can access it. It's still there now. I put a link in it for it, but it was also something presented to the community at large for an opportunity again to show that we need to remove these alerts. In May, Jeff presented to the Monroe County Medical Society Physician Pharmacy Subcommittee, and the idea there was to start to try to engage our community partners. So Rite Aid and Walgreens and Wegmans, who have committee members that sit on this committee, try to get this message out in front of them, so that we can, when physicians order cephalosporins and it goes out to the community pharmacy, and then the pharmacist calls you and says, "Hey, did you know this person has a penicillin allergy?" We're trying to stop that, and there's even work underway in the EHR record, so and a patient has a documented penicillin allergy, that there will be a little blurb that goes out along with the prescription saying, "We are aware of this, the benefits outweigh the risk," stuff like that. And so there's work to engage our community partners in how to do this. We continue to meet May and June again with the same groups. And this time we started pulling more team members from the St. John Fisher School of Pharmacy. The idea there, again, not only is this an issue for inpatient and outpatient and physicians, it's an issue for pharmacists. And so how do we get that message even further out into the community so that we can stop those annoying phone calls coming in saying, "Did you know your patient has a penicillin allergy?" And so that work has been underway and is ongoing, and there's still a ways to go. The most recent meeting, we kind of decided to break the team up into 3 different groups. One group is really going to focus on the IT aspects and how do we change the HRs in our systems? How do we get the notifications out? How do we, make prescriptions going outbound, have the right information? So again, to reduce and communicate that, yes, we are aware, you guys knew the patient had a penicillin allergy. It was purposeful that you're doing this, and it doesn't require a phone call back. Another team felt like, this is a good opportunity to do a study. So there's a team working on how do we structure a study around this. And then the third team is on education. So how do we get the message out amongst the community, amongst the pharmacy, amongst providers to increase awareness? And that's really the kind of the work that's been going on in this space around the cross-sensitivity alerts. I know Jessica Stern talked about the work to change and de-emphasize the penicillin allergy and remove it when it's inappropriate. And so I can see how these are going to start marrying together. So I'll pause and see what question you guys have right there. All right. That was mostly the recap I had on penicillin. So if we don't have any questions, happy to move on to the next presenter.
Perfect, Bob. Thank you very much for that. Really appreciate it. If any questions come up, feel free to bring them up at the end. Now we're going to move on to Elizabeth Sharp, who's going to give us a little topic on quality program topics.
Thanks so much. So I'm going to be bopping in and out of a presentation. I have a couple of slides for you, but I am also really looking for some feedback from the team here tonight. Let me share my screen and then hop into presentation mode. So what I wanted to do tonight is review our quality performance. I know that for the PCPs on the line, you're generally looking at the performance to our quality measures for your entire population. One of the things we do at AHP is monitor by line of business as well to make sure that we're performing top tier on all our different contracts. So I have some results, I guess, early results, mid-year results from our Excellus contract. and a couple of areas of concern. So I wanted to kind of set the stage for how we're doing in general. This is something we'd like to be bringing to this group a little bit more frequently. And then talk about a couple of the measures. You can see here colon cancer screening and the diabetic measures where we're looking for a little bit of input from you all. And then I wanted to just bring up to let you all know about a patient experience project that we're looking to do some analysis on this year and then hopefully launch in 2024. So very briefly, just to orient you to our Excelis contract, we have 3 different components in the quality section. The first is the ambulatory grid. So that's our quality measures. That's what you're used to seeing. We do select 10 measures for our docs to see. We often have more than that on our actual quality grid. We joke, it's not really a joke actually, that Chad has created this straight A report card. As we take in new measures, they're report only, so we don't always feel the need to display them. We also have a couple of measures that are a little bit more oriented towards specialists, and it just doesn't really seem fair to hold a PCP responsible if that's not a measure that they can impact. So the ambulatory grid is what everybody knows is our quality program, but there are a couple of other pieces as well. We have a quality improvement initiative, that's depression screen and follow-up, which I know everyone's heard me talk about ad nauseum for a couple of years. You got a couple more coming. And then the patient experience initiative, which I will be coming back around to at the end of this presentation. We're going to be looking at breast cancer screening there. So trailing year April 2023 performance. Whew. We have 3 different lines of business with Excelis. For our commercial contract, from a quality measure perspective, and that's what I'm going to be focusing on for this portion of our conversation, we've captured 60 out of 70 points. When you add in the patient experience and you add in the quality improvement initiative and then you apply the weights, thank goodness Christy Howd has created a beautiful scorecard for us that does this all automatically. Our total performance is 92 out of 100 points, which is top tier. The threshold that we have beat there is that 90 points overall, which means we're eligible for 75% of a gain and only responsible for 25% of a loss. So top of line there, which feels really good. Medicare, we've captured 64.5 out of 70 points. Again, when you add in those other 2 initiatives, we're at 96 out of 100 points. Same deal, top performance. And for Medicaid, we've captured 45.75 out of 70 points, which brings us to 81 points. So that threshold that we have beat is that 80-point threshold, where we would get 60% of the gain, 20%, be responsible for 20% of the loss. Last year, for the first year ever, we scored over 90 points in our Medicaid contract. Prior to that, we are usually in the 80s. So this performance isn't alarming, but it's certainly something that I'm interested in impacting and moving the needle on. Before I move on, does anybody have any questions? I realize this is probably a little bit of a different way to think about performance than what's normally presented to you all. Okay, I don't have the patience of Bob, so I'm moving on quickly. The measures that I wanted to talk about today, colon cancer screening first and foremost. So we saw a drop. Now this is comparing 2022 final to trailing year April 2023. So there is a lot of overlap in these 2 different time periods I'm comparing. We saw a drop in all 3 lines of business. I'm actually going to start with the Medicare. It's only a 2% drop. We're still at the 90th percentile. I'm going to be honest, I'm not overly concerned. We'll keep an eye on it. For commercial and Medicaid, we dropped 6% in both of those lines of business. Now for commercial, we're still at the 90th percentile because we were just that high above that threshold. But for Medicaid, that translates to a 2 quartile drop. So we dropped from the 90th to the 50th. Our denominators increased pretty dramatically, and we did have a change in the definition. So the bottom age range for colon cancer screening is no longer 50, it's now 45. And a full third of our open gaps in commercial and Medicaid are in that 5-year age range. So if you take a look at our gaps, a third of the gaps are people ages 45 to 50, and 2/3 are the 50 to 75. That indicates to me that a large portion of or large drive for this 6% decrease in performance is in fact that age range change. I rhymed, not even on purpose. And so this is the part I'm going to pop these questions up and I'm going to take us off so we can all look at each other's faces. Is this change something that you and your practices were aware of? Did you know that the guidance was shifting from the 50 to 45? How are you discussing this with patients? Is there any other issues in colon cancer screening that you're seeing that you'd like to bring up to us?
Elizabeth, before we answer those questions, how do you close the gap? Like, what are the tests that would close the gap?
So colonoscopies, a FIT, a Cologuard, I'm literally going to pull up the definition for how long they all last because I never remember this one off the top of my head. Willie's laughing at me, but he has these nice one-pagers on our website. So the colonoscopy lasts for 10 years. Does anybody know this off the top of
It
their head?
is
You guys
one-
are gonna make me
Three,
think.
3 years for Cologuard
Yep.
And
3
yearly
years Cologuard, 1 year for FIT.
and 1 year for Guaiac.
Colonoscopy is 1 year, I think, or
2.
FOBT is
It's
1
2.
year, flexible sigmoidoscopy is 5 years,
correct.
and FIT is 3. Look, we crowdsourced that. Well done, everyone.
And Guaiac is
So there
not,
are no,
and Guaiac is not one of them, correct?
Correct.
Correct. Okay. I think that's important to highlight because I think some people do use Guaiac, so that's an important, thing to recognize that is something, there has to be a transition from Guaiac to FIT. And that's why I wanted to ask that question out loud so that we understand that.
okay.
I will say, just commenting, that it's been really tricky because the insurances have now changed, but there was we only are aware of the change in the last year. So up until now, it's been okay, fine. The screening should start at 45, but we're not sure your commercial insurance will cover. Therefore, we'll try for maybe FIT for a couple of years until we're sure that there's capture by colonoscopy or Cologuard. So there's a lot of, there's always going to be a lag whenever they change the years. And I'm surprised that they didn't allow this sort of ramping up time frame that would be appropriate to any time you change, you group of 5, a 5-year cohort. We're only seeing their doctor perhaps once a year. So there's going to be a certain amount of lag time before they actually make it to their preventive exam, have that discussion. And then colonoscopies are so backlogged. It's another 6 months, sometimes 9 months before they actually can get their colonoscopy. I'm having some people do FIT saying, you should have a colonoscopy. Here's the FIT test to bide you through until you get your colonoscopy. But unless we do a strategy like that, FIT plus, we're going to have a huge lag for quite some time, is my thought here.
I agree
That
completely
same
with you, Valerie,
comment.
on that.
Yeah, that same comment came up in our leadership meeting, and it's certainly something we're going to be bringing back. It is a large cohort of patients to be adding to an already stressed system when you consider access to that colonoscopy. Any other thoughts in general?
I guess the other thing I would say is that younger group, that 45 to 50, they were all expecting to go at 50. They're more hesitant to do the colonoscopy. They're, well, do I really need it? Sure, I'll take the information, but they tend not to follow up. Whereas the older population tends to follow up, and I would say as you get to the 60 age group, they, get a colonoscopy and they're calling the person every week until they get the date, whereas the younger people, yeah, I'll get to it. And so you have a barrier just because they're not used to doing those things.
I will mention just a quick strategy that we use. I actually, in the drawers in my exam rooms, I have the FIT tests and I have the nurses label them up. And then if they're overdue, I hand it to them and they can just mail it back. Because otherwise, if you have them have to go back to the lab to pick up a FIT test to mail in, you're going to get about 80% dropout. So just, and the Guaiac cards, we used to do it in the office, but it doesn't count. But the FIT test you can actually hand to them. And if you don't put the labels on, so many come over unlabeled, it's not worth it. But if you get the nurses to get the labels on it, so it's pre-labeled, that seems to be the key thing. Also, then they feel that we really care. We're bothering to put a label on. They get the message.
That's really helpful. Thank you.
Great strategy.
Chad, anything else before you relaunch our
I
FIT
would
test
say
initiative
is-
and start walking around with them in your pocket again?
So 2 things. I mean, I think we know the backlog for colonoscopy is growing. So for years, we've held stable at about a 12 to 1500 wait list in the Rochester area pretty consistently throughout the year. That wait list has grown to about 2000 now. Some of that's the 45 age group. Some of that's just more people being referred. So, our access to colonoscopy, especially with OR staffing, Sawgrass having facilities closed down episodically, has definitely impacted the availability of the colonoscopy resource. For that reason, I think FIT testing for the appropriately selected low-risk population is a smart choice. The other thing, I think and this is crude and it's crass, but it's real. the fit test, it's a big sale to say, put a piece of newspaper or a piece of saran wrap over the toilet, poop on it, catch it, stab it, swab it, that's a whole lot. So we talked before, and maybe didn't emphasize this enough with the dry fit cards that we had access to at one time, the double wipe, for lack of a better explanation, wipe and then wipe it on the card. The loss in sensitivity was relatively minor, but if you look at the compliance with that, it's actually much higher because people don't like toilet hunting, for lack of a better explanation. So I think, those type of strategies and considerations, the liquid fit does have a higher sensitivity, but it's marginal. And the functional process of acquiring the sample is distasteful to many. So, I do think there may be, looking back towards the dry fit cards and that what I'll call the double wipe plan may be the superior strategy if we want to adopt the fit selection. I will also say, it's a good time to talk about it. And we went through this before. For a while, we had a very high utilization of Cologuard. Cologuard's a wonderful test. I think their marketing probably exceeded the true functional sensitivity and specificity of the test itself. To achieve what the sales agents were saying, you had to get that thing back to Wisconsin for processing in 24 hours in a temperature controlled fashion. The reality is most of the processing happens outside of 72 hours and it's sitting on a loading dock somewhere or FedEx, either in the hot sun or the freezing snow in Rochester. So the sensitivity degradation is fairly significant once you get to that 72-hour mark, and the cost is very significant. So it really should be colonoscopy is 1A, fit is 1B, and then Cologuard, CT colonoscopy, FlexSig, dealer's choice after that. All are reasonable, but the cost efficiency of those tests is much lower.
May I ask a question? My provider does an annual, as part of my annual GYN exam, does a fit on me every year. And I understand that there is an aspect of invasiveness to a physical for a man. Is that an opportunity to do the same thing? And is that reimbursable? And is that, possible?
That's exactly what I was going to say, that if you can do it as part of the GYN exam and part of as much as I hate it, a physical on a male, even though you probably don't get much out of a prostate part of the exam, that's another opportunity. And you can send it from the office. I think it counts. Is that true?
It does count.
Those of you? Yeah.
Yeah, I think your point, Laura, is exactly correct with the decreasing utilization of the prostate exam. There is less and less of a likelihood of acquiring the sample in the office. And obviously we all have a short period of time. So I think the GYNs have definitely been helpful to us. I think the fit during the annual GYN exam is a very common function that a lot of the GYNs follow. I know a lot of the PCPs who do women's health do the same thing. I think in men, as we've done less prostate exams, there just hasn't been the same opportunity, for lack of a better word. But certainly, although you're absolutely right, the compliance once people take it home diminishes and make it easier for them with the way we ask them to acquire the sample. I think we may see that improve.
That's what we do in our office. So for the male physicals, when we do the prostate exam, we do a fit test if they don't have a colonoscopy.
Yes.
The problem is, like Valerie pointed out, the 45-year-old guy may not come once a year. He may come every 2 years. And so that 1 year thing is not helpful.
Right.
I'll say
I'd
this.
just like to point out that this is.
Oh, I was just
Oh, go
going
ahead,
to
Renee.
mention that the prevalence of GYNs doing it, we discovered was regional. We were down in Binghamton yesterday visiting our friends in Lourdes, and that was a revelation to them. OBGYNs in Binghamton do not routinely perform fit. So it's another example of just how local healthcare can be, even right down to that.
I just wanted to give Chad kudos. This is by far the most polite he's been in any of our conversations about fit kits. So well done, sir. There's hope for you yet. I really appreciate everybody weighing in on this. We're going to be talking about this on the monthly COVID call in July, or AHP update call in July, Old Habits Die Hard. Just to make sure everyone's aware of the change, see if anyone has any input. I don't know that we'll generate a discussion quite like this in a group that large, but are hoping to bring some of these ideas forward. So with that, I'm going to now jump back into my presentation and move us along to diabetes. So we have seen a drop, not nearly as dramatic in A1C, again, across all three lines of business, across both diabetic measures, so A1C and diabetic eye exam, which has its own slide. For the A1C, the commercial dropped by 1%, Medicaid by 0.5%, Medicare by 3%. But those small percentage drops translated to changes in our performance from a quartile perspective. There was no measure definition change, but we did see a large threshold increase. So for the commercial, between 2.5% and 5.5% on the thresholds. So that obviously has a big impact, because what got you there won't get you here, and we saw a small decrease. Our denominators have increased a little bit. I'm going to give the overview of diabetic eye and then touch base on some theories here. So again, we saw that drop across both measures. More significant from a percentage perspective, so 8% on the commercial, 4% on Medicaid, 2% on Medicare. A similar increase in denominators. We did see those go up. It's not anything like the colon cancer screening. We also saw a threshold increase here, but smaller, so less impactful from a threshold perspective. One of the open questions that we are digging into, and I'd like to just take a moment here to thank Lily Nudigat and Bob Adams for diving in with me on this, is whether or not some of the changes to our denominators and our performance are because of some patients being erroneously put into the denominators. So we know that some of the weight loss drugs, if you will, Wegovy and Ozempic, can qualify a patient as a diabetic from a HEDIS perspective, when in fact that patient might not have diabetes. So that patient is not going to have an A1C, they're not going to have an eye exam, but they are going to be in your denominator. And so I guess the diabetic question, we don't have the targeted thing yet. I feel like for colon cancer screening, we still want to intervene, but we know the reason for the change in performance. For the diabetic measures, it's a little bit less clear. We have a couple of theories. We're still working on that kind of data validation and analysis. But I wanted to know if these changes in performance resonate with you in your practice. So are you discussing or implementing targeted interventions? Where can AHP help? Are you seeing just more actual diabetics? Are you concerned about the impact of these weight loss medications on your denominators? I just would love to hear kind of what you're seeing and thinking about this.
You know, I'll comment again, a couple of things. One of the real frustrations here is that you can't just do A1C screening on patients who are normal for a Medicare population. They actually have to have a pre-existing diagnosis, pre-diabetes, borderline diabetes. So if a person has been diabetic at one point in time and now 15 years later, they're normal A1C, and they say, drop out this code. I said, if I drop out the code, I'll never be able to check another A1C on you. You'll be charged it because it can't be done for screening. So, one of the problems, or for people who are trying to qualify for medications, metformin, they're kind of borderline. Are they pre-diabetic? Are they borderline? I worry a little bit about the capture, because again, there are competing incentives as to which way, whether people are up-coded or down-coded. When their A1C is 5.9 and 6, and maybe once was 6.4, once was 6.5, but that was a long time ago. And so I think we've got a lot of remnant diabetic patients who are not really at diabetic risk, and that's been a challenge for us in terms of how do you navigate that.
Elizabeth, there's a question in the chat. Are people with pre-diabetes counted as diabetic? Opto, urine, microalbumin counted, etc.
I am going to double check. I don't believe so. I'm like looking at Willie here. I believe we need that. I'm pulling up our definition. It's been too long. We need at least 2 valid outpatient telephone or online visits with a diagnosis of diabetes, or 1 acute inpatient encounter with a diagnosis of diabetes or a prescription for a diabetes medication during the measurement period of the prior year for all of those. So no, they should not. You need that diagnosis or the medication.
So just to clarify, metformin because metformin is used for PCOS, it's used for a lot of other things. Is that putting people into that category?
Yes, it would, unfortunately.
That's a huge problem, huge problem. There's a huge number of people. A lot of people now are using it in the anti-aging. There's just a lot of off target use of that medication in particular. So I would really watch that and watch whether there's any way to say that really shouldn't be the case if there isn't a corresponding A1C of 6.5 somewhere in the chart.
I think the other medication that falls under that would be the SGLT2s. Cardiology is using those a lot for heart failure. And so they can very possibly be on a Jardiance for SIGA and not have diabetes, but using it for heart failure.
And for renal insufficiency. It's also being used by the nephrologists.
Yeah,
So what I'm hearing from this group, and frankly from my conversations with Willie earlier, where we literally roped in Bob today, so don't have a lot of final feedback, is that clarity around the medications and what's coming from a medication perspective in terms of diagnosing someone effectively with diabetes would be helpful. Is that fair? Seeing some nods.
And
Okay,
we
we're going
probably
to pull
should
that
take it
together
back.
then.
Yeah, I was gonna
Oh,
say, I
go
think
ahead.
we should take it, I think we should take it back to Excellus and see, much like we do some kind of post hoc cleanup with influenza, if we can demonstrate, that the patient does not actively carry the diagnosis of diabetes or have laboratory proven, but they're on this drug for other purpose, that we can somehow exclude them from the denominator. It won't be easy, but we may need to do that because, I think all the points of what metformin gets used for and the cardiac and nephrology uses now are growing very rapidly. So I think we're going to see more of that, especially in our population.
Okay,
I just
thanks, Chad.
point out that Jana did note that polycystic ovary, that diagnosis is an exclusion criteria. So hopefully those folks that are using it off label are being excluded from the denominators.
Any other feedback on diabetes?
Is there an issue with ophthalmology reporting the diabetic eye exam as well? Is it where does that fit into play?
I can't answer that either way just yet, but I think there may be. I know that historically we've had trouble with capturing the actual diabetic retinopathy as opposed to just a generic eye exam. So I think that's a good thing to poke into as well as we do a little bit more analysis here.
And to think about that, same thing with the colonoscopy, having just onboarded onto Epic, one of the things I've realized is that when a GI doctor does a colonoscopy, they don't close the gap. It still falls on the responsibility of the PCP to close that gap and put the metric in the computer. And so if we didn't get a report, now in Epic, we obviously do, but if you're a non-Epic provider and you're not getting a report, or you're an Epic provider and your GI doctor's not on Epic, that colonoscopy might not be captured. Right now, if you capture it on cost from the insurance, that's a separate issue.
So for this performance, we do. It might be a little delayed. Now, we ran this report in early June for a trailing year of April. So we generally use a 3-month run out rather instead of a 2. So we probably haven't captured everything from a claims perspective, but we should have captured the majority of those claims. The challenge is whatever issues we're seeing. I mean, there's a possibility things could be different, but in general, whatever issues we're seeing in this Excellus population, we're also going to be seeing in our entire population. And we don't have that claims overlay for our non-contracted members. And that's what we're holding our PCPs accountable for. So we need to make sure that we're addressing those EMR capture issues regardless.
One more comment that we've had a kind of a discussion back and forth with our data managers. People will have had a diabetic eye exam and they say, well, we don't see the word dilated. And if they don't see the word dilated, they don't accept it. So, and then that's a teaching point for and then we send it back and they say, well, we did the appropriate diabetic eye exam. We're not going to do another, they already had it. So there's a lot of back and forth sometimes on that verbiage. So we may want to work with getting everyone on the same page there.
Okay. Thank you. That's really helpful feedback. I also know that access is an issue for diabetic eye exams, for any eye exams at this point, as well. And so that's something that I'm not sure how I'm going to fix, but it's something that we want to be considering as we talk about this quality measure.
Elizabeth, do you want to speak a little bit to the way our data coordinators are doing like document hunting for some patients that aren't covered by insurance where we have claims access?
Yeah, absolutely. So one of the things that our data coordination team does for their practices is essentially takes a look at the gap list and goes out hunting. To Renee's point, they look in the Rio, they look in Epic, they look in all the various systems and sources they have. And if they find a colonoscopy that was completed that's not documented in EMR, or an eye exam that was not sent back or routed to that PCP office, they grab it, they pull it down, they save it, according to the practice's practice, to make sure that that is captured and also is available for the primary care team when they see the patient next, to know that it's been done and be able to see the results. We definitely plan on having them be a part of whatever initiatives and outreach we are going to be lifting. I do anticipate you'll be hearing more about this in a variety of forums. This is kind of the first time we've brought it external. We just ran these numbers earlier this month, had a chance to talk with our leadership team about it. Geez, was it this Monday? It seems like it was years ago. I went to Binghamton on Wednesday, so I've had a long week. It was lovely, but it's far. And so we are going to be talking to the network about this. We're still sort of in that data analysis, choosing our interventions moment, but wanted to leverage this team to figure out if you guys have any insight, and then we're going to be bringing that forward. So you'll definitely be hearing more from us when we have targeted interventions or things that AHP is looking to lift between now and the end of the year. With that, I have one more update. This one's not going to require full team participation afterwards. Let me share my screen again real quickly. So we did want to let you all know we are working again with Excelis. This is my Excelis presentation apparently, on a patient experience project. So this is a 3-year project. Actually, it started last year, believe it or not, where Excelis sent out what they were referring to as pulse surveys, very much like Press Ganey, to patients to understand a variety of categories. We have selected working on impacting access to specialty care. So one of the things that we wanted to do was engage around this project. It's a large part of our quality program, hopefully with minimal impact to our PCPs. And we wanted to align it with work we were already doing. So the initiative we selected here is actually breast cancer screening. We know that there aren't any huge, well, we've been told there aren't any huge access issues here. We do see a discrepancy between our commercial and Medicare performance, which was sitting at the end of 2022 at 87%, and our Medicaid performance, which was 68% of patients captured. So don't love that disparity. We're looking to potentially impact that too. But basically what we're doing here in 2023, we have a targeted data coordination chase at one of our rural practices. So the data coordinator is actually reaching out to patients to try and get them scheduled. We have a data coordination outreach, really the document retrieval component that Renee was talking about just a moment ago, for our Medicaid population, to see if there are any that are missing. We don't anticipate there are going to be any that we've missed because of that claims overlay, but wanted to make sure that we're capturing all the mammograms that are happening. And then a deep dive analysis into the gaps and access. So where are our gaps? Where do these patients live? Where do they seek primary care? How old are they? And then sort of flipping that on its head, where are they going? And what is the access like at those? Is there a wait? Are they on a bus line? Do they have weekend or evening hours? Is it easy enough to get an appointment? So we want to understand the landscape a little bit better. Then in 2024, we're going to be reviewing the AHP data. And then Excelis is going to be rebaselining that pulse survey in 2023. As we're doing our work, they're going to be doing some of theirs, and then determine some clinical interventions to make sure that the patient experience, can improve, patients feel supported and gaining access to this care. So more to come here. I just wanted to mention it to you all so you know that it's a thing, because you may be hearing about it in the future. And we'll certainly bring any interesting findings that we have to this group to share as we learn more. So I'm happy to take any questions on that. I'm also happy to pass the baton.
Thank you very much, Elizabeth. And now we'll return to Renee here to talk a little bit about the PCP reward plan.
Thank you. Before I get started with that, the announcement that I wanted to make in the beginning of our meeting, and then I became distracted. I want to share with you now. So hopefully folks can see my screen, and I have in front of them a little communication from Excelis that went out yesterday. And this concerns our U of R health plan, which AHP, of course, is the tier 1 provider for that health plan. So when U of R members keep their care in the AHP system, they pay less out of pocket. The health plan has decided and are announcing that effective September 1st, 2023, there's going to be a change to benefits that will mean that for health plan members receiving these services from an AHP provider, that prior auth will no longer be required. So that's in-network patient admissions and SNF admissions, home health care, organ and tissue transplants, DME over $200, high cost imaging, anything that would normally require Evacor, CareCore, they're calling it these days, and experimental and investigational services. So that means if you are an AHP provider who's rendering that service, prior auth isn't required. And for those services where like high cost imaging comes to mind, where the entity or the individual responsible for obtaining the prior auth is typically the PCP ordering the study, that the ordering provider has to be an AHP. So it's both the ordering provider where relevant, where it's the ordering provider who needs to obtain prior auth, and then the rendering provider. So both of those need to be in AHP in order for prior auth to be waived for U of R health plan members. So this is new. We have some questions out to the plan about exactly how this will work. We're interested in particular about the plan for post review, because that will still post-service medical necessity review will still be a thing, and we want to know how that's going to be managed. So as we learn more about what this means operationally, we'll share that with you. We want to make you aware of it, and that is effective September 1st. So I'll pause there before I go into PCP reward plan, see if there's any questions. Dr. Newman thinks it's great news. That is good news, definitely. No? Okay. Well, if any questions occur to you, please let us know. We'll be elevating this news more widely, certainly pushing it out via our various newsletters. We'll talk about it at the AHP update call in July as well, because by then we hopefully will have some additional information to share with the network about what this will mean for them. So if there isn't anything else about that, I'll share my screen again to share my presentation to talk about the PCP reward plan. And you're probably like, oh, again, how many times is this going to be on this agenda? But for as many times as we've talked to you about it, and what we've talked to you about is this piece, how those, the breakdown, right? Quality measures are worth 50%, depression screening is worth 10%, right? We've talked about what those individual components are worth, but we've never talked to you about, well, okay, but what does that mean? How do I earn the 10% in depression screening? What is the action? What is the threshold? So we wanted to give you a quick run through of that. I went into this in great detail at the practice managers meeting earlier this month, because those folks that really wanted to give that kind of granular detail. I'm going to go a little more higher level here, but I just did want to make you aware that the real nitty gritty was absolutely shared with your practice administrators. So what the slide in front of you shows is just for an individual for a given specialty, how the weighting of each component for the total reward, what it means. So family medicine, typically a provider, just about all of these components will apply for a family medicine provider. So quality measures is worth 50%, and then you can see all the rest down. But for internal medicine, they're not going to have an opportunity in LARC, long-acting reversible contraception. They've been excluded from that component. So that 15% that it's worth for family medicine rolls up into quality measures for internal medicine. So now I'll just also make a quick plug for the PER. you know that the quality measures where you want to see, you're going to go to Arcadia to see how you're doing on quality measures, right? But for all those other components, it's the provider engagement report where you're going to see how you're performing and what your progress is towards incentive for those other components. So just wanted to point that out, and we'll talk a little bit more on the PER. But back to the quality measure issue. So for providers, that's going to be their biggest chunk of the biggest component of their incentive is going to be their performance to quality measures, and it's going to be their performance to those 10 quality measures that are on our provider facing grid. So how does a provider earn that full 50% of the incentive, or maybe even all the way up to 80% of their incentive might be quality measure performance? And it's based on, just as it was in prior years, really, the percentage of points captured. So we still have like that gold, silver, bronze, but now it's just for that quality performance component, and you'll earn 100% of your quality measure component if you have captured 75% or more of the points that you're eligible for. And all the rest of that table shows is, for family medicine, that's going to mean 75 or more points. For internal medicine, it's going to be 45 or more points. For pediatrics, it's going to be 30 or more points, just reflecting that you're held accountable. The denominator of your points is the points you're eligible for. Family medicine is pretty much responsible for all of them, but internal medicine and pediatrics, that reflects that they're responsible for fewer points. So quality measures, if you want to earn 100% of that quality measure component, you're looking to earn 75% or more of your points. And again, Arcadia is really the most reliable source of that, or easily accessible information. We don't have that on the PER yet. Everything else I'm about to talk about, though, the PER is where you're going to go to see how you're performing and what your progress is towards incentive. What I'm going to cover first, though, are all the components that apply to all providers. So we talked about quality measures. The other two that will apply to all providers are depression screen and follow-up, and citizenship. So how do you earn the 15% for depression screening? How do you earn that full 15%? There's two paths to earn it. Either you're going to achieve, and I'm sorry, I should back up. This is a practice level incentive. We are going to look at the practice and see if they, as a practice for all of their patients ages 12 and over, did the practice achieve a rate of 75% or greater in depression screening? And if the practice did, that's great. Then every provider in the practice who's part of the PCP reward plan will earn the full 15% component for depression screening. But if they didn't, if the practice didn't achieve that, you got another run at it. And that is, well, did you improve over your prior year? Did you achieve a 15% increase in screening rates from your prior year? And if you did, then the whole practice earns that 15%. So you really have two shots at that. And of course, follow-up is a part of the measure, but the follow-up isn't included in the reward at this point. It's just about the screening rate. So either the whole practice earns that, has achieved that 75% or greater rate. If they haven't, then the whole practice has at least achieved a 15% improvement over their prior year. Absent either of those scenarios, then the practice does not earn the 15% component for depression screen and follow-up. How you are monitoring the practice's performance in depression screening is here in the provider engagement report, which not only shows you the practice's progress and how they're doing, it also is a source of actionable data that you can click in and pull up your full patient list of patients who have not been screened. I'm going to pause here not only for your questions, but also to ask Elizabeth, who is our I'm sorry, Elizabeth's off camera, so maybe it's not a good moment for her, but if it is a good moment, if she wanted to comment at all on depression, on the depression screening and PER. Or if you have any.
I'm happy to answer any questions that folks have. And I will note that you and your teams, not necessarily you, sorry, I have a small person here now. Your team will be hearing from Kate Sharma, who's on my team, about your depression screening data. We want folks to be comfortable with and log into the PER, but we also want to make sure we're bringing this data forward to you. So you will be hearing from us over the next couple of weeks to make sure that that data is front and center for you and you feel comfortable with how everything's displaying.
Okay. If there are any questions, I'll move on. So citizenship, this is one that we've talked about a lot, and the PER is where you're going to find that information. And we are awarding this first based on a practice level. We're checking to see, did the practice do some activities all together that would qualify every provider in the practice for the citizenship component, the full 15%. Or if not, if the practice didn't do those things, then we will drop down and look at every provider to see if on an individual basis, they've done the things that qualify them for the citizenship. At the practice level, what this looks like is that your practice manager has attended 2 or more practice manager meetings in 23. If it's, we're also looking to see if you're participating in an optimization or administrative project or an IPC like collaborative care, trauma-informed primary care pilot, comprehensive developmental screening pilot. So if you're a practice who's participating in one of those, and your practice manager has attended 2 or more practice manager meetings in 23, let's say, for example, then everyone in that practice has satisfied citizenship and will earn citizenship. And other practice level components include the practice is implemented on the PER by 12/31, or the practice is met with the pharmacy team. And we're tracking those meetings and we're tracking those PER implementations. And you'll be able to look on the PER to see how you're doing for citizenship shortly. That component is being built out right now. For an individual basis, let's say the practice didn't accomplish those things, so we need to drop down and see how the individual providers are. We're tracking, did you go to clinical grand rounds? Do you agree to receive our email communications? Everyone in this committee is getting 1 check at least for serving on the adult advisory committee, or serving on the board or a board committee, or you're completing 20% of your targeted VATICA visits for the Medicare line of business. So just doing 2 or more of those things on this list would earn an individual provider the citizenship component. I'll move on to pharmacy cost savings. And this is one that providers have several opportunities to earn the component. Your performance is being judged in 4 prescribing classes. And if within each class, the provider's performance is at or above the network average, then the provider will earn 100% of that component for that class. If you didn't, though, you have another run at it. Again, did you do better though than your own record from the prior year? And if you did, if you beat your own average, then you'll earn 50% of the award for that class. This is also available to folks through the provider engagement report. That's going to show providers right there if they're meeting the mark or not within those individual prescribing classes. And then when you click into the PER for pharmacy, you also have an opportunity, again, for actionable data to download a list of patients for whom a switch is, they've been identified as someone who could be switched to a lower cost drug. I think what's good for providers to understand here and why it's very important to log into the PER or have someone log in and review those patient lists is that there is an opportunity that if you don't agree that that patient is a candidate to be switched, that you can bring that to the attention of our pharmacy team for review and an opportunity, if they agree, to remove that patient from your denominator. So the fact that this patient isn't a good candidate for a switch doesn't impact your performance. And then I should pause there and ask Bob if he'd have anything he'd add or if there's any questions about pharmacy.
No, I think you did an excellent job outlining it. And again, just, you feel free to reach out to us and our team if you find candidates or patients you want to discuss and feel like, well, they've tried Lantus and the generic biosimilar for Lantus and they feel like it didn't work for them or they had some reactions, then we can discuss that and see if there's opportunity to move that patient from your denominator.
Thanks, Bob. And then the final component of the incentive plan is LARC, long-acting reversible contraception. So this is considered a cost savings initiative, really, to so our pediatric providers can have some access to a cost savings initiative, since there really isn't much opportunity for them currently that we could identify in the pharmacy space. So to satisfy, first of all, for who is eligible to be part of this component, it's going to be providers who have I'm sorry, your faces are blocking my notes. These are providers in the PCP reward plan who have the specialty of pediatrics, family medicine, or med peds, who also have 10 or more female patients ages 15 to 20 at the time the initial reward plan data is pulled. So if you are a provider who meets that description, you have those specialties and your patient panel includes 10 or more female patients ages 15 to 20, LARC is a component for which you will be held accountable. Providers with a specialty of internal medicine or geriatrics are automatically excluded. And of course, if you're a provider, a pediatrician or family medicine who don't meet the critical mass of 10 or more female patients, then you'll be excluded as well. And all you need to do to satisfy it, to earn that full LARC component, is to attend a reproductive health counseling training in between January 2019 and year-end 2023. And for providers who have actually on their own gone and attended and had the actual Nexplanon placement training, and who can provide proof that they've completed that training, they may also reach out to provide that proof and then be considered that they have satisfied the LARC component of the reward plan. So that is my summary, high level. I hope that wasn't too dull. I'll only say one thing I think it's important to remind folks is that when we talk, we've really been trying to message PCP reward plan, PCP reward plan. How are we funding that? Well, that's gain sharing. When we're talking about what we're paying out for the PCP reward plan, that's the PCP component. That's your share of gain share. That's where it's funded from. But we just wanted to, I thought it was important to make sure that folks understood that when we're talking PCP reward plan, that's your share of gain sharing, and trying to develop an incentive plan that's really well aligned with the accountabilities that AHP has as a network. Prior to this reward plan, it was all just really about the quality measures and the size of your panel. Now we've tried to make it a little more sophisticated and include those cost savings components, since as a network, that's how we get gain share. We save money. So this will always be evolving to reflect what our accountabilities are contractually, and what the challenges are that we in particular need PCP's assistance with. So any feedback on that? Any questions about that? I would also just remind folks, as far as timing, the PCP reward plan was implemented in 2022. And as we've announced a couple times via network news or at this meeting, we are holding providers really harmless for 2022. You didn't have the access to the data you needed to really move the needle. So that 2022 PCP reward plan will be more or less really paid out on an equitable basis. So we're anticipating, we did receive board approval for just the other night for the gain sharing distribution for 2022. And just as it has been in years past, 60% of what we're distributing is going to PCPs. So that's very much in keeping what it has always been. And what that 60%, how it's paid out, is the PCP reward plan, and that we anticipate that payment will be made sometime in I'm going to say the August timeframe. I think there's a desire to get it out sooner than that, and if I have good news about that, I'll certainly share it. But I think August you'll definitely have your payout by then. Any questions?
Renee, something that might be helpful would be, again, to share how to log in to see your PER and to be able to access your data. That might be something that may be helpful for everyone to have that re-education.
Sure. Is that something you'd like me to do now, Diego, or do you want me to plan that out and we can do a PER deep dive? I would love that if folks wouldn't mind waiting until our next meeting, only because I think we'll have more additional components built out in the PER, be more interesting to see live. But you should know that we certainly are working hard to get it implemented. Many of your practice managers do have this access, much like how Arcadia may be managed in your practice by resources other than you. We anticipate the same thing for the PER, but absolutely any provider, any physician that wants access to it, would be happy to give it to them.
Well, if it's better to do it in a later date, that's fine. I just think we should know how to do it when we're interested in logging in.
Absolutely.
Any other questions? Very good. Any other topics to discuss for today's meeting? Grand rounds is being planned for October. We're going to have hopefully a bunch of speakers lined up based on the suggestions from our last meeting in May, both in chronic kidney disease as well as HDHD. So we'll be working on those and get more information as soon as we have that available to us. And see no further questions. I think we'll adjourn at 7:15. So thank you very much. Have a happy 4th, everybody. Thank you for attending, and we'll be seeing each other in person at the next one, which is very exciting. More details to come.
Have a good night, everyone.
Good
Have a
night.
great